All right, let's talk about blood pressure a little bit in stroke patients, and then I think we'll transition into talking about the VAN a little bit and VAN Plus. So we talk a lot about hypotension with stroke patients, and the big question is, like, should I treat that? What blood pressure am I trying to maintain? You know, with a trauma patient, we're looking for that mean arterial pressure of 65, and we're looking for that systolic blood pressure of 90.
About 90,
but
yeah.
with a stroke patient, that's a little bit different, right? So we talked a little bit off camera of we're trying to maintain that 100 systolic blood pressure. Do you want to elaborate a little bit as to why, Kelly?
Sure. First, I would say, like, probably the majority of the patients that we're thinking stroke probably have a hypertension. One, obviously, number one risk factor, and then oftentimes it could be your body's way to hyperperfuse the brain. So your body's reacting and trying to perfuse the brain, and get that blood pressure up. So I think, yes, we don't want to drop that blood pressure too far. Even with our hemorrhagic patients, we do have concern, dropping them too low too quick. So we like to kind of have a range between 130 to 150. Right away, acutely, we just aimed for 160 because we are so scared that we are going to drop it too low till we get like the neurosurgeons in for our hemorrhagic patients. But so that's the point where we don't want to get to less than 90. We want to keep it at least above 100.
Sure.
Sadly.
We want to make sure we're still perfusing that patient's brain
Correct.
adequately. And then on the flip side of that,
I'll go one step further. I'd say we're shooting for normotensive in these stroke patients.
These patients.
Yeah.
Okay.
I want to avoid hypotension in these patients because they're going to be hypertensive, right?
Yes.
We're going to see very common to be minimum 160s to 180s, even above 200s in these stroke patients. Above 220 systolic is too high, and in our protocol it's red box, so you can give medications for that. Obviously, call and have that discussion. And you're going to have 2 blood pressures above that. And the reason for that is that's going to be our goal. We're treating them without thrombolytics in the emergency department. We have even tighter goals to get them lower if they're getting thrombolytics in the emergency department. But if it's a bleed, we're going to have 140 to 160, depending upon who you talk to, what their blood pressure is, and
what week it is.
Yeah, exactly. Because the change has been to now push them lower.
Yep.
But to the point, we don't want to correct them too fast. We do the same thing with anyone that's hypertensive. If you're coming in with a hypertensive emergency, we really don't want to change you more than 25% in that first 24 hours because your brain's so used to having that high
it's
blood
set
pressure.
To that.
Yeah. Yes. If I drop your blood pressure, all of a sudden there's watershed areas, those areas of your brain that don't get a lot of blood flow to them. They're just used to having that high blood pressure. So if I bottom it out, I'm going to cause a stroke.
Correct. Yeah, because you're not perfusing that area.
So it's a complicated thing, and that's why it's red box in protocol to give those hypertensive medications in stroke patients, because it's a complicated process and a complicated conversation that we're going to have. If we're going to give thrombolytics, I know that I need to get blood pressure down because the life-saving intervention in that case is going to be the thrombolytic. Right. That's what they need. We're going to target our medications to that, and we have multiple levels of medications that we give. You guys have labetalol in the protocol, which is one of our go-to medications, but we'll do hydralazine, we'll do labetalol, we'll do nicardipine drips, and then getting really into the weeds, depending upon their vasculature, we might choose we might go to nicardipine if they have like a known aneurysm or something like that. There's medications we choose for different niche purposes, but blood pressure control is a complicated thing to kind of manage that we're doing in concert with our neurospecialists.
And the point I want to make on the converse of all the hypertension that you were just speaking to is that hypotension in the stroke patient makes me wonder what else is going on, right? It's what am I missing in this story, right? Is there a concurrent overdose with something that's bringing blood pressure down, or that shouldn't be a normal state of being, right? Of course, you could have somebody with stroke symptoms and that is hypotensive, but to your point, we should see that escalation of blood pressure. So it's a suspicious finding in and of itself, right?
Well, I'll throw a curveball at you. Let's say someone's poorly controlled hypertensive. They're used to being 180s over 110s.
And great point.
They double take their hypertensive medications, they bottom out, and now they're having a stroke because they're not perfusing their brain.
Going back to your watershed.
We're going to manage those differently.
Yeah.
And I think it's just to your point. I think you both had two great points there too. If you have a question about managing the patient's blood pressure, call medical control.
Just
We're
call
very
us.
pro that in our system. Have the conversation with the physician, have the back history, and then if your patient is hypotensive, continue to look as to why are they hypotensive. Continue to go down that pathway. It's almost like I look at the altered mental status. It could be one of these 500 things.
Right, exactly.
Well, keep looking, not just
keep turning the stones
their blood
over.
pressure is hypotensive, and not want to try to figure out why. Continue to figure out why. I think as a provider in the field, so to continue your hunt, for lack of a better word.
I actually have a question, and this is probably for our non-EMS listeners. So when there's you have somebody on for medical control. So Dr. Hill, you do that. Are you guys covering the whole system at one? Like, is there one person on call, or do they call you always?
We're regionalized. So you're calling. So if it's a UH med control, they're going to call whatever hospital they're assigned to. So it's ever their regional places. So they'll call the squad line. Squad line's not answered by a doc. It's answered by either a nurse or a paramedic.
Okay.
UH Portage. And they're like, I need to talk to a doc. All right, hold on. And they literally just hand the phone over to us.
Gotcha.
So a few seconds later, they'll be on the phone. I introduce myself. Hi, it's Dr. Hill. And they go, hi, I'm Scott. I'm a paramedic with Beaver Township. I tell them, like, tell me what your question is and then tell me what's going on so I know what to listen to. I got a stroke patient. I want to give hypertensive med soup. Great. I know what we're talking about.
Yep.
They'll tell me the last one. Well, all of that blood pressure is 230 over 120. I'm 30 minutes out from getting to a place. I want to give 10 milligrams labetalol. Is that okay? Short, concise. They know what they know what they want to give, why they want to give it. If it's protocol, I'm going to say yes to those people. But it's regional. We don't have, and we have talked about making it more system wide. The caveat to how our system's set up, and I don't know of any places that are really system driven. Although UPMC
would be the model, closest to us.
Yeah, I don't know of any in Ohio where it's EMS med directors that are answering that call. It's just going to be an ER doctor.
Okay.
Now,
even in those systems, there's a communication specialist kind of in between, right?
Yeah.
Yeah. It's not like you're sitting there answering there's still that initial level of triage,
Sure,
right?
sure.
Which is.
But
can I help you, or do you really need to talk about
yeah, what's your question?
Did you try harder? Try harder, and then call me back.
But it's going to be most places this day. If you're working in ER, you're going to be a board-certified emergency medicine physician anyways. They can handle the majority of those calls. Those ER doctors may not know the ins and outs of what protocol is. To that point, I'm an EMS medical director, and I don't know the ins and outs of protocol, and I will pull up protocol all the time to talk about what does protocol say type of deal.
Sure.
So sometimes it's better to say, hey, protocol tells me to do this. I need to, yes, it's okay. I need to call you to get permission to do this thing that I want to do. If you're giving me a great story as to why you want to do it and you understand the pathophysiology of it and why you want to give it, yeah, I'm all for it. If it's a him and han, I'm going to be less likely to give that okay to give it. But if you know your protocol and you know why you're going to give it, 9 times out of 10 we're going to say yes.
That's a lot. We spend a lot of time coaching the providers, like, here's how to get the most out of that phone call, right? And he kind of gave you the framework for it, but knowing what you're trying to do, where you want to go, not just help. Hey, here's my problem, and here's where I want to go with it, or anything I'm missing. Of course, is going to be far better received than just a cry for help.
I think it's a great question because we talk about it a lot and on a lot of podcasts because I almost want to say there was like a stigma behind it.
Absolutely,
and I think we've hopefully helped try to change that over the past 2 years that we've been doing this like, come hell or high water, I don't want to call that doctor. Like, I don't want to call, I don't want to bother them, or they're going to be grumpy or this, and it's like, we're very blessed in our system to have such engaged medical directors and physicians, and that's why it's so important to have any type of education we do. We have all the specialties included in that. And so when you call, it's kind of like, you said, it's confident. This is what I'm calling for. This is what I know what I can do. This is how my patient presents. Do you agree with me giving this patient labetalol? And this is why I want to do it. And, that helps. And a lot of times too, the ER physician that you're talking to is going to receive that patient as well too. So that's a huge, like, I might call you back in a little bit. If I'm that 30-minute ETA squad where I called for that order for labetalol and, doc says, well, how far out are you? 45 minutes. I'll call you back and give you more of the story in a little while, or see if the patient changed or improved, things of that nature. But I think we've really tried to break down those those barriers, for lack of a better word, of the old like stigma. Don't call and speak to the physician. Where
And
we're blessed in that
Yeah.
area of it.
If they're overloaded, even especially cognitively, and I talk a lot about cognitive overload for those providers, I want them to call just to say help. Fine, I will help you with this situation. In that case, I'm not going to probably tell you okay to give labetalol because, although beneficial, risk-benefit discussion in my brain, do I want to have an unsure provider give a medication that could cause
Potentially harm.
significant harm
Sure.
in those patients? The answer is no. As opposed to, it's more like if you've listened to like doc consult calls, especially from the ED.
Sure.
Hi, I'm Dr. Hill, Dr. Scott. I want to do this for this reason. Are you okay? Yeah. It's a
goes over
15,
way
20-second conversation. They might bring up a few points that I didn't consider, or I might bring up points like, hey, these are the significant things that I'm concerned about. This is why I want to do it. Is this okay, or do you have another recommendation? It's a very short consult call. We'll move on to the next thing.
Or I'm vacillating based on this one
Yeah.
point. Yeah.
Yeah, that's a good point. Actually, that's not the best medication to give. Let's consider a
Yeah.
different medication for the reason that you're vacillating over. Yeah.
I think, and also just wanted to mention, I think that's like part of our culture too, that we want you guys to make those phone calls, but we also want you to bring those patients in if you are just, have just that little inkling that this could be a stroke. We expect those overcalls and we, encourage them. So we don't want you guys to be nervous or get in trouble for bringing a stroke that isn't, or a potential stroke that isn't a stroke.
Sure.
I'm okay with any of the, we talked about time-sensitive medicine, and that's what this is. Stroke, STEBIs, traumas, sepsis. Those are time-sensitive issues. I want you to overcall those.
Yeah.
The guy I talked about that had the aphasia, EMS asked for a pre-hospital stroke alert. No lateralizing findings. It was just kind of aphasia. Didn't really fit a picture. He was drinking at a bar. I want to see him first.
Sure.
Arrives, I go bedside. I'm going through it, and I just say, yeah, let's call it. And we activated based upon EMS told me to. Maybe I should have listened. I wasn't convinced.
Yeah.
I saw the patient like, yeah, we did. And he ended up getting TNK, and he ended up getting better.
Awesome.
His NAH went from maybe he went 8, 9, I think, down to like 1 by the time we left the ED.
That's awesome.
But that was a big conversation with the neurologist there, like, and he is the one who considered them for TNK as I was putting orders in because he had a complicated history, he had a prior stroke, and had a bleed from, he had hemorrhagic conversion of that stroke post TPA from like 6 years ago or something.
Wow.
So it was a longer conversation of
Sure.
can we consent this person for thrombolytics, and ended up being a good outcome.
And I got to imagine it's easier to de-escalate a team than it is to stand them up if
Definitely.
going
right.
back to your point about overcalling some of these things that maybe we're on the fence about.
Yeah. Yeah.
Well, and even
Patient outcomes.
behind the scenes, when we activate that stroke and we're putting in orders and we're going to talk to our stroke neurologists, we've already in triaging. We have a 2-tiered system of, are they emergent and have their thrombolytic candidate, or are they outside the window? And they're going to be a little bit less priority because I don't have any really acute interventions I can do right now.
Sure.
We're going to do our tests, and they're triaging too, right? They might have, I've got 4 strokes coming in, and
Of
I
course,
need to
right.
know where do I need to go.
Yeah.
And if it's the ER doctor, like, I don't need to talk to you right now, get caught up and we'll have a conversation later type deal. That's a good, that's already built into our system.
I think just to mention, like, that is very new in our system
Yes.
of January this year, that we implemented telestroke at all our system hospitals. So every stroke patient coming into that emergency room within the 24-hour window is being seen very acutely by a stroke provider.
And we're having multiple conversations with them during that process.
We do have very strong emergency medicine providers, I have to say, though, and we will even encourage them to, if it's a straightforward TNK case, we encourage them to, go ahead and treat those still, like prior to
Yeah,
getting that
and there's
telescope
times I'll get a
consult
call, hey, they're having like, yeah, TNK is already on board, flight's in, what more do you want to do? Like,
Yeah.
nothing. Like, okay,
Yeah.
see them downtown.
Great relationship, though.
Yeah.
And that's like you said the culture word. And I think that's what we're really talking about today is just the culture of EMS, the culture of working with UH neurology, ED physicians, how it's a team approach. And that's how the patient wins and how we have the best outcome. All right, let's talk a little bit about the van, right? So we talk about, previously we used to do ASLS, Advanced Stroke Life Support.
The MEND exam.
The MEND exam, Miami Emergency Neurologic Deficit exam, I believe.
Sure.
I'm impressed with that you remember that.
Yes. I liked that class a lot. It was like, before in EMS we just had the Cincinnati Stroke Scale and that was it. We did arm drift, slurred speech, facial droop, and then it was like, okay, yeah, stroke, no stroke, get a blood sugar. And I think ASLS really opened our providers' eyes to do more of like a 12 lead of the brain to try to understand different parts of the brain, where the stroke is actually happening at, why the patient presents the way they do, right? Is that fair assessment?
When we initially started doing the Cincy, it was do this because I said so.
Yeah,
Right.
sure.
The MEND exam tied with ASLS was here's why.
Why?
Right.
Right.
And then going back to the previous discussion about the provider seeing imagery and seeing what's behind the curtain, that gives you more confidence to
Yes. Speak.
better assess
Yeah.
and optimize patient care.
Well, that advanced stroke care is important, right? I like the whole thing, 12 lead of the brain, because if you're doing a good neurological assessment, you can tell me where the lesion is based upon that assessment.
Yeah.
So based on how they're presenting, what their neurodeficits are, you can tell me, that's more likely going to be an MCA stroke, depending upon how high their NIH is and what their overall deficits are. You can be, that's probably going to be a large vessel occlusion.
Kind of hones you in on the area to look.
Yeah.
Yeah.
Well, and honestly, what we do in the emergency department is when I'm putting my orders in, I'm telling the neuroradiologists where do I essentially think the lesion is. I'm telling them like it's left-sided deficits. If I give them as much information as I can, like
Sure.
slurred speech, left-sided deficits, so they know kind of where to kind of hone in on. And that's the same place that I'm looking when those images roll by, like which side of the brain am I looking at, left or right?
Sure.
And then if it's when I'm looking at CTAs, which I admit I'm not the best at CTAs, I'm still looking left or right based upon whatever symptoms they're presenting with. So I'm giving them as much information as they can because
That helps them
radiology,
as well. Yeah.
they're not seeing the patient, right?
Sure.
They want as much information from me. Stroke evaluation is not helpful for them. Yeah, great. I can look for bleeds, but if I say, and if I just say it's isolated left lower leg, that's a different, very specific part of the brain than like, it's facial droop, left upper, left lower.
Right.
Left lower leg would be less likely to be a stroke based upon where it's at, but it gives them more specific parts to where to look into the brain, even look for that subacute changes to see, is this been going on for 6-12 hours? I don't see any changes in that specific spot where I'd expect it to be.
And we've said this 100 times too. It's the pattern recognition that comes with
Exactly.
emergency medicine
Yep.
that tells us where it's at, right? And your 12 lead analogy, if they haven't connected, it's the pattern of SD segment elevation. We can immediately go back to a particular coronary artery, right? And you're making
2-3 AVF is right side, right?
Yeah.
Exactly right.
Correct.
It
really
you're
hones you
doing
into it.
exactly the same thing, just with your physical assessment.
Yes, just with the neurovasculature, not the
cardiovascular.
vasculature.
Yeah.
Yeah, so I thought that was a phenomenal program, great education to EMS. All the stroke coordinators from all the different hospitals were always involved, always there with EMS, and I think that is just part of our culture. And then we kind of changed gears and went to the VAN assessment. So where we're looking for that LVO, we're doing that assessment for that large vessel occlusion.
What prompted that? I mean, I know the answer to that. Yeah. That was the loaded question, but that was a fundamental that was a big swing,
Yes.
right? Because we were coming in with the MEND, which is, I don't want to call it a voluminous, but it's a wider net, and then we shaped that down.
So I think the MEND is a little bit more closely related to the NIH, which is looking
Yes.
at the whole brain,
Yep.
where a lot of protocols, and I believe like EMS across the nation, really wanted severity scales.
Yeah.
So that's why we kind of had to choose a different scale rather than the MEND, and we ended up going with the VAN.
Yeah, which primarily is going to tell us about a large vessel,
And-
and really focus on that. If you're not familiar with the VAN, I'm very pro. Like if it's not something you do every day, I'm very pro. It's in the protocol. It's on if you're in our system, obviously in Ohio, and also under UH Medical Command, you can use our OneDose app. You can use our protocol that's available on our website. VAN also has an app. Vision, aphasia, neglect is kind of the high points of it. And it has some points from the MEND exam, like, we used to test 4 quadrants of vision for their peripheral vision because someone that has a stroke, typically they're going to lose the peripheral vision on that affected side. And the VAN honed in on, well, we don't need to test all 4 quadrants. We just need to test each side. Where It's a very simplistic test. It will actually, yes, it'll give you a score rating if you use the app, which I tend to use. And then it's also baked into a lot of our ePCR platforms that our providers use under UH's protocols.
But I think the other big thing that I wanted to point out from the kind of transition into the severity score and looking for the large acute things, the large vessel occlusions, the LVOs, a lot of that was driven at the state of Ohio said, hey, we're gonna treat this time sensitive medicine like it should be treated, right? And historically we didn't have that mandate. It was very, very regionalized, right? We were doing Mend up here. People were, still doing Cincinnati. It was a mixed bag, right? Sure. And the state came out and said, we need you to do a consistent thing across the state, and it be standardized and
submit our submit our protocols to the state even too. Yeah.
And it needs to drive your destination. I know that's lower on your list there, and we'll get down to that destination selection. But that was, part of that was mandated, of course.
Sure.
We got told.
Well, and why we have those short scores is NIH takes a little bit to do. Yeah. I don't typically get a full NIH done on my patients before they go to CAT scan. Right. I do a broad brush stroke of lateralizing signs. I typically only I can assess their speech, whether they're slurring or not. I guess aphasia. Those are all kind of like doorway things that you can identify in the 100%. Patient. So probably one thing I do is I do sensation, I do motor, and then I do arm drift on all the patients, and that's probably all I get done before they get to the CAT scan. Because I can do lateralizing, and then I have drift, and it gives me more information. But then I don't get my full NIH done until after imaging.
And then you can finish. Sure. You can finish the picture afterwards. Yeah.
Yep. And I think I kind of brushed over this, so I kind of want to dive a little bit deeper into this. So when we get into the VAN assessment, obviously the first thing we're going to do is arm drift. If they do not have arm drift, they're VAN negative, that's going to immediately stop you. If they have arm drift, arm weakness, you can move down our algorithm here. Then we talk about vision. Can you see my finger essentially on each side? We're testing peripheral vision on the left and on the right side. Another thing that ASLS teaches us, Van talks about it a little bit, I know we've taught it as a system as well, is if you have that patient that is just, their eyes are just stuck to the left or their eyes are just stuck to the right, typically their eyes are looking at the affected portion of the brain. They're looking towards the stroke. Some of us have taught that in education. That's a good thing. You talked about aphasia. So we talk about expressive aphasia. So I, hold this up and it gives an example of like a pen. You hold out a pen. Hi, Dr. John, what can you tell me what this is? You want to see if they're able to say and, announce that that's a pen, or are they having issues, like are they saying truck or, July, or are they just not giving you the appropriate word? So I'm having an expressive aphasia problem.
Verbal diarrhea.
Yes, right. Or do we have receptive aphasia where they're not able to follow your commands, which you gave a really good example about earlier. And then also we get into neglect. Are they neglecting one portion of their body? I think it's Dr. Spanner. We talked about that where he walked into a patient's room and was just like, hello, I'm Dr. Spanner. Good to see you. And it's nothing. Okay. And then goes around to the other side of the bed and he's like, hello, I'm Dr. Spanner. He's like, oh
hi.
Hi. And he's, okay. So he's neglecting completely the entire right side of his body, peripheral vision. You start checking those boxes without, in theory, doing that specific test, but it's instantly seen. And then specifically at university hospitals, we have what's called the VAN Plus. So we've added two things that we want our EMS providers, because we're trying to look for that posterior stroke or that cerebellum stroke, where we'll do finger to nose testing with both left and right arm, and then heel to shin. And that is extremely important to do. And I have a small story that I'll use. So we go on a call. It's like 3 a.m. And it was really weird. It was like a 58-year-old male with weakness. I'm like, why'd this guy call 911 at 3 a.m.? This is really weird. He's talking to me. He's ANO times 4. We're having a normal conversation like the rest of us are. And I'm like, okay, Cincinnati negative. All right, take his blood pressure. Maybe had a little bit of hypertension, nothing crazy. Glucose is fine. We go through this. I'm like, it's just something seems off. I don't want to leave this guy at home. Get him in the truck. And that's when we did mend then. So I go through the whole mend. And then I get to finger to nose, heel to shin, and he fails finger to nose and heel to shin. And when those patients fail that, And when EMS providers are doing this test, you want to make sure you get full extension of their arm, right? We don't want it to be.
That won't show you ataxia.
No, I don't want this. It's. I want them out and reaching, and that's exactly what he did. He couldn't do it.
Yeah.
He can communicate with me just fine, you know? So when he fails that and we do heel to shin, he looks, what's wrong with me? Like, we're having this conversation. And I was like, I believe you're having a cerebellum stroke. And he was just like, how the hell do you know that? You know? And I'm like, I knew something was wrong with this guy. I just couldn't figure it out.
I just did a 12 lead on your brain.
Yeah, just 12 lead on your brain. And I'm like, and I hate to tell stories, but like that one was very impactful because it's like, well, it's 3 a.m. The guy's presenting like normal, talking, everything's for the most part fine, 12 lead EKG, fine, like all this stuff. And you get all the way down to the med exam and you get to the last 2 parts of it. Yeah. And we test that posterior part of the brain and he fails it. And I call, and I'll never forget this, and I don't think he'll mind. And I get Rob Musali. And, Bob and I get along very well. He's the ER physician at my destination hospital that'll remain nameless. And the nurse answers the phone. I was like, I want to speak to the physician. And she was like, why? I was like, I have a cerebellum stroke. She was like, you have what? and excuse me? I was like, can you just put the doctor on the phone?
Put him on the phone.
And he get on the phone. He's like, it literally opens with this. And I love Bob. He was like, you either know what the hell you're talking about or really wanted to talk to me. And I was like, I have a cerebellum stroke. The patient's failing, finger to nose and heel to shin. They're not coordinated. The patient's this.
Yeah.
All right. So you know what the hell you're talking about. Sounds great.
Yeah.
All right, cool. I'll meet you like at the doors when you get here, but some of these items, whether it's MEND or VAN, and I know what we use now, Cincinnati and VAN Plus at UH, and that's very important, have been plucked from the NIH, and they're simple tools to be able to be done. But that instant, just me explaining that this is why I have this, and the physician's like, yeah, 100%. And I followed up, patient had a cerebellum stroke, so it's very important for us not to forget the plus part of this exam. If you're doing, you do your Cincy, you do your VAN, continue on and still, go down that rabbit hole of making sure you're doing testing the posterior part, because how many posterior strokes are missed? Right?
Tons. That's why it's so impressive that you even picked that up. Yeah. So kudos to you.
That was my one fancy thing in my career. Teasing.
I have one.
But I've won.
I missed 40.
I know, but I
got that one.
I know I got that one, but I used that example, and it sounds bad, but because it was just the patient was so alert. I hate to use that is my example.
Everything else is clean.
Everything else is fine. We're having a full-blown conversation like everything is normal, but it was like I think he essentially summed it up with unsteady gait would probably be my complaint where I started. And it's just like, well, I went down that rabbit hole of like, I want to figure this out. It doesn't make sense to me. Yeah. So, we want our providers and our system and our culture is why we've added on the plus part of the VAN exam. We want you to go down that rabbit hole and test that so we don't miss a posterior stroke. And I'm sure that any nurse or physician answering the phone, hey, I want a stroke alert because I have a posterior stroke. They failed finger to nose, heel to shin. They're like, oh, okay. All right,
Kelly, talk about some of the other subtle stroke things that.
So I think anything sudden is a big trigger. I think that we should really think of with posterior circulation, dizziness. Sir Dr. Hill, he probably sees dizziness all day long complaints. so it is, I think, really hard to tease out which ones they should be activating. So we try to stay like dizziness plus. So dizziness plus something else, dizziness plus a headache, and especially that sudden onset is a big trigger. But a disconjugated gaze. Like eyes are, look in different directions. The dysarthria, slurred speech, dysphagia or aphasia. But anything that comes on sudden, I think that's when we really start thinking like this could really be a stroke. And I think we say a lot of times with the headache part, we may see some headaches though with our ischemic stroke patients even, or like a PCA stroke. We've seen that several times. So I think like even though we're thinking, oh, they got a sudden headache, this could just be the hemorrhagic stroke. I think we still have to consider that it could still be an ischemic stroke, especially with these dizziness patients.
Yeah. Dizziness has been a big thing this year in the emergency department that essentially now all of them are getting NIH scores. Yeah.
Awesome.
In the ED. So that's a big focus for us in emergency medicine just for this year. And talking about VAN Plus, I think we need to expand our VAN Plus to be just general ataxia. That's finger to nose, heel to shin, but truncal ataxia, right?
Yeah.
One of my recent patients had like a lean to the side. She's like, I'm leaning. I don't know why I'm leaning. Well, that's because you're having a stroke. Yeah. Or they're just not stable with their trunk. Like they're kind of all over the place. Like, and dizziness. I think we need to have a higher suspicion to those to be strokes. and we'll do our stroke workup. Let's prove it's not a stroke, right?
Especially with those risk factors too. Take that in consideration if they have a lot of those risk factors.
Well, I mean, most patients that roll into the ER are going to be high risk anyways, right?
True.
If we're talking about heart attacks and we have a heart score, there's lots of people that roll in. You're a moderate risk just walking in the door if you say you have chest pain. Right. So guidelines say I should keep you in the hospital, but your baseline, if I have a headache, well, if I look at a heart score, you're moderate risk to have a heart attack in the next 6 weeks. So these patients that come in, their baseline risk to have a stroke is very high. We need to at least look at that and assess it and either prove it's not or then make some modifications to reduce their risk of stroke in the next 3 months.
And one other point is age. I think we're seeing a lot more younger strokes. So sometimes we see these patients and you're like,
great point.
I'm not going to, this probably isn't
they're
the
young.
real
They
thing.
can't be having a stroke.
They're too young, yeah.
Yeah, they're too young.
The 35-year-old COVID patient came in 2 days later with arm weakness. Yeah, there was a stroke on CAT scan.
Beautiful. Yeah, great point.
The one thing we didn't talk about was like pediatric stroke a little bit. Typically that younger patient would historically present more so be a bleed as well, just for us to kind of be aware of that younger population. And those can go with like congenital defects and other, that could be a whole conversation as well. But even to your point, the younger population, this is something we should always perform. And I kind of like the way you said that of, let's just prove it's not a stroke, right? If I'm going down my list and I can't figure out what's wrong with this patient, maybe this is a good time to talk about some of the mimics, is why not just prove it wrong then? There's nothing wrong with going through all of these exams, checking all the bases so that when you do get to the hospital, you could say, well, I've done this, 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 and this, and this. And maybe I still don't have the why or the what, but I've done all of this and I still can't figure out X. So, and it's just a good way to communicate with the ED physician, nurses, things of that nature. So, I like the way you said that, John.
With pediatric strokes, so the majority of those are going to go to main campus. So interesting enough, we do treat these patients. A couple months ago, well, I think it was probably actually like early last year or so, but we treated a patient with a thrombectomy. He is in high school, and how he had I believe it was a basilar occlusion.
Wow.
And he came just recently to our stroke symposium, and he just made the soccer team. So seeing how devastating it was stroke and a pediatric patient getting the treatment, it's pretty cool.
And now he's back sports.
Yeah.
That's awesome.
Yeah.
That's amazing.
It's pretty cool.
That's amazing.
That's a hell of a story.
And that, and that's really, somebody identifying that stroke and thinking it could be, could this be?
Yeah, could this be a stroke?
And a teenager,
Wow. Yeah, that's mind-boggling. That's crazy. So some of the stroke mimics, I think, probably some of the things we just need to cover, and we'll see if anything we missed. So we talk about migraines, right? Some people could have just that detrimental migraine with light sensitivity, worst headache of my life. Maybe they haven't been diagnosed with migraines yet. So we could possibly think, was this a subarachnoid? What were you doing? What was the story? Good story pass on to the ED. But migraines could just be debilitating for some people, especially untreated migraines. Low blood sugar, we kind of tease that out. We're good there. Seizures, right? Somebody that has a seizure, they come out, they're postictal. Maybe they don't have a history of seizures, or it's not treated very well, managed very well, and that body has a seizure, and all you get muscle contraction, and you use their oxygen demand just goes through the roof. So, this patient needs oxygen. We definitely want to check their blood glucose and see where they landed, because this large consumption of that in the brain not storing any oxygen and glucose and it needing it is definitely something we need to think about. And, Bell's palsy, whether it's just maybe focalized just to the face, or are there other parts of their body, that are affected from it? Any input on that? Some of the mimics, something I forgot maybe?
I've given
and we already hit that
thrombolytics to Bell's palsy patient. We obviously beat hypoglycemia to death. Seizure, any weakness after a seizure is going to be called Todd's paralysis. It's colloquially what it's known as, and those are not strokes unless I've never given a Todd's paralysis. Always ask seizure history. The one we talked about where I almost gave thrombolytics to was a Todd's paralysis patient that had happened before. Complex migraine, they're going to typically have that already. Like, they're going to have some history of that. It's kind of same with seizures. They're going to maybe have a prior history of seizures. Yep. Infection can obviously cause it. This could be how a tumor presents. We unfortunately see that all the time that we go to get that non-con CT, and oh, good God, there's a big old tumor that's taken up half the brain volume. So that's why they're having stroke-like symptoms. Obviously, there's trauma concern. We're going to worry about it being a bleed there. So conversion disorder is also another thing that we have to tease out. It's very hard because they're very convincing that that's what's going on. Peripheral vertigo is going to be vertigo only. Also, it goes with that dizziness thing that we want to talk about that. Syncope can also mimic it as well.
For sure.
Total global amnesia.
Oh, yeah.
Not something that we see very often, but I've made the diagnosis once. And then stroke recrudence. So if they've had a prior stroke and something changes, they're fighting infection, their stroke symptoms might come back temporarily and then kind of go away once they become more back to their baseline.
Sure. And I think our message to providers are doing a good assessment, doing all the stroke scales. If you think it's possibly a mimic, just communicate that well. And it's okay to also, I think sometimes I always, you guys always make fun of me. I'm the bread and butter paramedic of, like, I always want to communicate that to the hospital. Yeah. So if I don't know, I have enough pride in myself to say, I don't know if this is Todd's paralysis or if they're having a stroke. I just want to communicate that to the physician. I'm going to put the ball in your court, and I have this, and this, and this. This is what's up.
You're just articulating that you've done a differential diagnosis.
Yeah,
right?
And I think that's important.
I know what it's not.
Correct.
Right. Yeah. Here's what I'm down to.
Yep. These two things.
I can't suss these things out because I don't do imagery in the truck yet.
I like the yet. Yeah. We're not there yet. We're getting there.
We're heading there. Come on. I mean, we know that.
But our mantra in our system and our culture is just call it. Just call it, right? Yeah. Just pre-activate, call it. It's not going to. I always get this question a lot when I taught CEs. Was that going to cost the patient a lot of money? No, it's not.
Right.
It's not like there's going to be this massive charge just because you're like, hey, I'm between these two things, so I'd rather just call it a stroke and say, like, I'm going to go with the worst case. I think this patient's having a stroke. And
so it really kind of does 2 to 3 things. It notifies the ER that we need a room because there may not be a room available. So it might say, oh, we're not going to bring that patient back.
An acute room.
Yeah.
Not a hall bed, not an ENT room, right?
And we need to clear the CAT scanner. CAT scanner needs to be available for us to go directly to the CAT scan. So it notifies the ER, you need a room, notifies CT, I need a CAT scanner. Yep. That's all it does.
Yeah. It frees it up, but it's also very easy to cancel.
Yeah.
Right? So we would rather in our system and our message of we want you to activate based on what you see, tell us that. We would rather activate and overactivate than have a miss, right? We don't want that.
And I think even Dr. Hill's saying that he treated a mimic before. I think that is expected even from our stroke neurologists. So you guys miss calling. I mean, sometimes we mistreat, but even those patients that are getting the maybe additional treatment that didn't need it, usually those patients are going to be safe and not have a hemorrhagic conversion or anything like that.
And often, there are cases where we're talking about the things that mimic stroke here, but stroke can also mimic other things. And I know you guys have heard my story. When I was a young paramedic, I got burned on what turned out to be a midbrain bleed, a podneal bleed. And how did it present? It presented with pinpoint pupils or constricted pupils, altered mental status, and respiratory depression. Well, that checks all the boxes for an opiate overdose.
Yep.
What did young paramedic Scott do? After 4 or 5 gallons of Narcan and nothing was working, right? Well, you're taught in school, right? It's a narcotic overdose. It's narcotic. And I'm like, I don't know. You had 47 doses of Narcan in my care, and nothing changed. And the doc, that's all he had to hear, right? And he's like, it's a midbrain bleed, and
because he's seen it before.
And again, going back to your case earlier about the imagery, I happened to come back to that same hospital later in the afternoon, and I'm like, what happened? Connect all these dots for me. And he was just showing me the imagery, and I was like, okay, that makes perfect sense, right? From a physiology standpoint, but that mimic can work both ways in this one particular case, right? Yeah.
That's a good point. And I think we're so lucky, and I know we talk a lot about our system and where we are dependent upon where our listeners are, what country they're in, what state they're in, but I think that really is our uniqueness of university hospitals, the EMSI, our partnerships with all the time critical medicine, neurology of, when the education is put out, to your point, is these are real cases. Yeah. That's just so invaluable. I think when neurology makes those PowerPoints with pictures. You know, we're all firemen, we like pictures, but it really drives home of like, we did mechanical thrombectomy, like, yeah, okay, and then it's like, here's the clot we pulled out, and they're like, oh, like they all look at it like it's shock and awe.
Yeah,
and we give all of those different types of cases that present that way to the emergency room, and you see their whole path of to how they were discharged, whether they went to a skilled nursing facility, what type of rehab they did, and then how they returned essentially back out in the world. And I think our system does an extraordinary job on that, you know, and I just want to say thank you for that, because that's huge. I think it really brings the education full circle of their interactiveness of all of our partners and how it is a huge team approach, whether it's EMS to UH Portage to CMC to UH Neurology or HHVI. That really, you know, all those partners or trauma, that really changes care, in my opinion.
Yeah.
And that means something to me. And, you know, that's why we want to deliver the best care to that stroke patient. And we all learn from those cases too, of, you know, the physicians even say, hey, I had this rare case the other day, let me explain it to you. And we all learn from that. And it's just extraordinary. What did I miss? I did a terrible job at leading this thing, but what did I miss?
The only thing that I want to touch on that I didn't touch on earlier is we're talking about where, like, we have these different levels of stroke centers. In UH, we use the OneDose app. So on OneDose, if you go to contacts, we have categorized all of our local area hospitals, what capabilities they have.
Oh, that's
so
awesome.
they can pick comprehensive stroke, thrombectomy capable,
In a sort by list.
and a sort by list.
Yeah.
If you have like a slide or anything like that, will you share that with me? Just
Yeah, of
because
course.
I didn't
We'll
know.
give you access to one.
No, it's ours. It's ours. You can't have it.
Great.
Yeah.
So that's just another resource that you don't know what's there, that
Yeah.
we have specifically built that. And you're like, oh, I want to be able to go to comprehensive. It just pops up all the comprehensive strokes. You can choose whatever one you want to go to.
That's awesome.
And then it's got phone numbers for them to call for report.
Sure.
I'm very passionate about this topic. I like talking about this topic. But really, what we do owe is, Kelly, do you have anything else? Anything else? You think we missed, or-
Takeaways for takeaways for EMS.
I think just don't be afraid to call. Give us that early notification. And we truly do appreciate you guys, because you guys really lead the stroke care that the patient's going to get and really impact patient outcomes. And I don't think you guys get to see that or hear that enough. But thank you guys all. Thank everyone.
Thank you. Thank you for being here. Thank you for putting up with us and our shenanigans.
It was fun.
Hopefully it was fun. But seriously, yeah. And I look forward to being on the live with everybody again in the near future. So
Can't wait till the live.
can't wait until the live. So we want to thank everybody for listening. And remember, you can go to prehospitalparadigm.com to review our content. You can get
All the
free
show
CE,
notes,
all the show notes, all the outtakes, all the mistakes, all the fun
I don't know
laughs.
if you shared that with me.
Oh, yes. But yeah, no, it's this is where all of our content is kind of stored as our landing page. And but thank you so much for Kelly for being here. We really appreciate it
you.
and appreciate your time.
Appreciate the opportunity.
All right. We'll see you later, everybody.
Next time.